Hello, I'm Heidi Wittenberg. I'm a gender affirmation surgeon in San Francisco and wanted to talk about gender expansive options for vaginoplasty. There are two versions out there available, and if we're going to be talking about vaginoplasties with penile preservation, is the two grafts available for the lining is skin grafting, which is usually from the scrotum, or two, adding on this newer procedure that I'll go more in depth into, is the peritoneal pull through technique. Now, for patients who are not as interested in a full depth vagina or really want to commit to having a 12 to 13 centimeter depth vagina, we would pretty much be talking about a peritoneal pull through procedure. And that's because we are not using the skin of the penile shaft like we would for a full vaginoplasty that included a penectomy. We have to get that tissue and lining from somewhere else. Now, if you have enough scrotal tissue to do that depth, we can offer that. Sometimes that's too hard to know ahead of time, and that's something we have to decide in the operating room. So really deciding on what depth you would really need for you to really complete your inner sense of well-being. Second of all is the more tissue we use for vaginal depth for skin is the less that's available for creating labia later on. For my patients who have done gender expansive penile preservation vaginoplasties, realize that for the most part we are going to have to come back for a second procedure for a more definitive labioplasty. We will try to do it. I try to do it all at once on the first time, but I think we just need more skin for the labia, so touch-ups are going to be needed as a second stage procedure. Ideally, that's 6 to 12 months after the first procedure. Now, for patients who definitely need a full depth and don't have enough tissue for the vaginal lining, a newer procedure called a peritoneal pull through option is out there. And I know in the blogosphere there's a lot of information that's out there. I know the thing is like, oh, more depth, lubrication, less maintenance. We don't know any of these for sure, and I think that's something that we really need to look into. In the cisgender oral gynecology, where this procedure was developed for people who were born without vaginas, is GYNs originated this technique by going abdominally, obtaining some graft from the upper portion and surgically making an upper portion of a vaginal canal, marrying it with going down below and doing a perineal vaginal dissection, and those two openings meeting up, opening up together for a continuous vaginal canal, and then dragging down the peritoneal lining that's still attached by its original origin or pedicle to peritoneum, wrapping the vaginal canal, and therefore bringing the lining all the way to the vaginal opening. That I call a primary vaginoplasty technique with penile preservation, and that is not a hybrid. Also out in the blogosphere is whether someone uses a hybrid technique or a full vaginal lining technique. Hybrid, I think, is used in different ways. One, if someone's having a revision surgery for skin lining they already had that's collapsed down, and we're trying to now augment or marry or revise the vagina by adding peritoneum with the abdominal laparoscopic approach, but still keeping the healthy vaginal original skin graft that's present, removing any of the upper portion or scar that is occluding or shortening the vaginal canal. The other definition of hybrid is, I think some surgeons, general surgeons, urologists may be going in laparoscopically, obtaining a portion of peritoneum, bringing it out, and then going down below from a perineal approach pelvic approach, and then placing that lining, that graft, for the deeper portion of the vagina, like we would a skin graft, so not attached to its original pedicle. So 2 different procedures. For primary vaginoplasty with penile preservation, we are doing 2 procedures. We're doing a perineal vaginal dissection from down below, then we're going up above and using laparoscopic, and a lot of times also using the robot as an assisting tool for laparoscopy to obtain enough vaginal graft still attached to its original pedicle, placing it down, as we were also making surgical dissection, opening up the top of the vagina from above, placing the lining where it should be in the vaginal canal, and then closing the aperture, the opening at the top of the vaginal canal, closing the abdominal incisions, and then completing the procedure down below. So, what's the longevity? What are the stats on this? We don't know. Even in the cisgender world, gynecologic world, the biggest study was 36 patients performed in India, and of those patients, only 3 were followed long-term, like 7 years, and what they followed for was depth and if they were able to have sex. So their depth that they calculated for patients was 8 centimeters, which was enough to put a speculum in, and which is a natal depth for vaginas. They didn't follow necessarily lubrication, dilation, any other issues. So I think that's what we do need to follow from here on out. And anybody signing up for the peritoneal grafting technique or pull-through technique needs to know that we don't know the longevity or issues that'll come up. I know in the last 2 years of my 20-year Urogyne pelvic reconstructive career, before becoming 100% transgender, gender affirmation, gender expansive surgeon, is that I had 2 patients referred to me that had complications and strictures. One of them from the vaginal pull-through, peritoneal pull-through technique, and one of them had a 10 centimeter mass from having a stricture at the top of the vagina, and fluid had been accumulating over the years, and we had to remove that. So if someone is signing up for this, you are in the forerunner of patients, and we would need to be following you for issues that are short-term and long-term. I would also want you to commit to doing all the dilation and maintenance that a skin vaginoplasty requires. So the long-term dilation, the douching, all the maintenance that in the blogosphere says you don't need for peritoneal pull-through. I want you to do that. We'll adjust with time as we find out the success rate or issues or strictures that happen with the peritoneal pull-through technique. In this last year, I've performed 10 peritoneal pull-through procedures, and the depth has varied from 8 to 15 centimeters. Lubrication is there, although for one patient in their 4th month, they had decreased lubrication. Lubrication is continuous. It is not variable based on excitation or on demand. It's a steady discharge. I've had a couple patients with strictures at the scar rings a little bit at the top portion of the vagina. Those have softened with time, but again requiring dilation. So again, realizing that this is a forerunner procedure, I feel lucky enough that I have the background surgically of doing pelvic reconstructive surgery and having dealt with rectal fistulas, bladder fistulas, prolapse, and have also specialized in minimally invasive surgery. I'm a master surgeon in laparoscopic and robotic surgery, that I am now made for this procedure. I have marrying all my prior 20 years of experience with my now coming up 4 years experience of doing gender affirmation surgery. So marrying those two together in this particular procedure called the peritoneal pull through. I think things to ask your surgeons, and it's always good to get second opinions, is how many penile preservation procedures have they done? How many peritoneal pull through procedures have they done? What are their statistics on vaginoplasties, even penile inversion technique? What are their stats and complications for that? Because that they should know. And that's part of the consult I have with my patients when we're talking about vaginoplasties. And being transparent, the number of procedures they've done, their background and training. Again, I feel fortunate enough that I've had a surgical career that allows me to do this procedure from start to finish and deal with issues that arise. Mostly this arena, this surgical field, is plastic surgeons that do need to group together a team of different specialty surgeons to provide peritoneal pull through technique for their patients. So just asking if they have their regular group, what are their rates so far of complications, what's their experience. I do feel lucky enough, like I said, having experience in the background and being the one surgeon from start to finish, that I am making your procedure and recovery as efficient and optimized as we can. Look forward to meeting you. I hope this helps.